Okay, this is the second part of chapter 48. We're going to start with seizure disorders on page 1011. A seizure can be also a symptom of epilepsy or other type of neurological disorders related to like a brain tumor or meningitis. Epilepsy is a chronic neurological disorder that's characterized by recurrent seizure activity. Seizures are either classified as partial or generalized. Partial seizures start on one side of the cerebral cortex, and in some cases the electrical discharge spreads to the other hemisphere, and then the seizure becomes a generalized. Generalized seizures are characterized by involvement of both cerebral hemispheres, so it's on actually both sides of the brain. Epilepsy it can be acquired or idiopathic. Idiopathic just simply means that it's an unknown cause. There is lots of different causes that can cause epilepsy, but if it's what we call idiopathic epilepsy, the most common time for the patients to start having idiopathic epilepsy usually is around the age of before 20. If you start getting seizures after this age, most commonly then this because we have a neurological disorder that's underlying. Signs and symptoms, it really depends on exactly the symptoms are going to, the seizure activity is going to be correlate with the area of the brain where the seizure begins. So, it's hard to say that everybody's going to have the exact same symptoms. Typically with partial seizures, patients have what we call automatisms, and that's a repetitive, purposeless behavior, which is a classic symptom of partial seizures. The patient appears to be in a dreamlike state when picking up his or her clothing, chewing, smacking his or her lips. A lot of times this patient may even be considered like a mentally ill patient because of some of the unacceptable social behaviors. They may spit, they may fondle themselves, when in essence they don't have a mental illness, they're actually having a seizure. Typically this patient doesn't lose consciousness, if they don't lose the consciousness, then we say it's a simple partial seizure, usually lasts about a minute. If they actually lose consciousness, then it's considered a complex partial seizure, and that's going to usually last a little bit longer, about 2 to 15 minutes. The post-ictal period is the recovery period after a seizure, and sometimes the post-ictal phase may be no more than a few minutes of disorientation. General seizures affect the entire brain. There's two types. There's the absent seizure and a tonic-clonic seizure. Absent seizures we call petit mal seizures because they usually are just a period of staring that lasts a few seconds. If it's a tonic-clonic seizures, which is the one that most people all automatically think about, that's also called a grand mal seizure or convulsion. It's usually where the patient is, the tonic phase lasts about 30 to 60 seconds. It's characterized by rigidity, causing the patient to fall if not lying down. Their pupils become very fixed and dilated. Their hands and jaws are clenched. The patient may temporarily stop breathing. When it goes to the clonic phase, that's when you start having contraction and relaxation of all the muscles. That's when you get that jerky, rhythmic fashion. The extremities can move forcibly, causing injury if the patient strikes furniture or walls. And then obviously with the tonic-clonic seizure, which is a generalized seizure, that's when we typically start having injuries. The patient a lot of times will become incontinent. They bite their lips or their tongue. I've seen patients that have injured themselves quite a bit. They've fractured their face. They've bit their tongue in half. They've had to have sutures. So these can be quite violent seizures. With a tonic-clonic seizure, Obviously, the post-ictal time is a lot longer. For some patients, it might be 30 minutes, but in other patients, it may be hours long. Diagnostic test, the EEG is the most useful test to evaluate seizures. So we can actually hook them up to the EEG, determine where the brain, which part of the brain the actual seizure starts. We look at the frequency and the duration. Then they can also look to see, are they having asymptomatic seizures. They may also do sleep deprivation and flashing light stimulation test to see, does that bring on those seizures. Therapeutic measures, obviously, if we can't really find the cause, then we just try to treat the symptoms so that they don't have seizures at all, or maybe just slowing down the seizure activity. There is a lot of anticonvulsive medications that are available. The patient can be started on one medication and then increased until they get therapeutic levels. If they're not controlled with one single medication, sometimes they may add the second medication as well. You should really warn your patient never to stop the anticonvulsive medication. They need to taper off of it slowly per the manufacturer's instructions. Stopping the medication abruptly could cause them to have an actual seizure again. There is surgical management interventions that we can do. A lot of times some of the surgeries that they may do is, they may put in like so they go in and they actually try to block the signals that are going to a certain part of that brain by putting I can't even think of the name of it right this minute, but it's kind of like a stimulator to stimulate another part of the brain so that one part of the brain is kind of basically being ignored. Emergency care is required when a seizure occurs. The biggest thing that we need to be paying attention to is to prevent injury. So if we have side rails, we always want to pad them just to prevent that patient from striking or hitting against them. If the patient falls to the floor, move all the furniture away from the actual patient, out of the way. It's very important we maintain a patent airway. So if we can, we want to turn them on to one of their sides to prevent aspiration, especially if they vomit. Never, ever put anything in a patient's mouth once that seizure has begun. We want to, years ago they said, put a bite block in their mouth, put a tongue depressor so they don't swallow their tongue. We've learned that we do not want to do any of that, so you don't want to put anything in their mouth. The biggest thing that once a patient starts having a seizure, is we really are there just to prevent them from being injured. We want to observe and document their behavior during the seizure. We want to pay attention to what part of the body was first involved, what was the progression of the seizure, the time that it lasted, and after the seizure, you want to really pay attention to the patient's breathing. If you have to suction them, then you can. In rare cases, we do have to perform CPR or rescue breathing. So that may be something you may have to do. Status epilepticus is characterized by 30 minutes of repetitive seizure activity without a return of consciousness. This is a medical emergency, requires very fast interventions to prevent irreversible neurologic damage. If status epilepticus was to occur out, say in the public, obviously you're going to call 911 and you're going to try to get help as fast as possible. If this happens on the medical unit, like say in the hospital, you're going to have this patient transferred to the ICU unit immediately, because this is something that has to have immediate treatment. These patients are going to require adequate oxygenation. So, like I said, we want to get this patient transferred to the ICU. They're going to be intubated. A lot of times they're going to be on a ventilator. If it's to where you can't get them on a ventilator, then you're probably going to have to bag this patient. IV Valium and Ativan is administered to try to stop the seizure activity. If you don't have an IV line, they can give Valium rectally. Both of these drugs do cause respiratory depression, so we got to look at their airway management very closely. And so we're really watching, making sure they're breathing okay. Also, too, after we're going to obtain serum drug levels. We may give an anti-convulsive therapy. We may have to adjust it to get our therapeutic levels again. If the seizures remain resistant to all the other treatment, then we might give a barbiturate coma. So they actually would give their barbiturate pentobarbital, and then they would induce them into an actual coma. We don't really want to give them general anesthesia, but occasionally they do have to do that because, they can't get the seizure activity to stop. If they were to be in a coma or they were to be paralyzed by medications, both of these therapies require the patient to be intubated, be with mechanical ventilation, and then obviously, they're going to be in that ICU setting. We're also going to continuously monitor that EEG. And you can look at the table 48.5 on page 1013 for the all the medication examples and then nursing implications there. All right. So now we're going to go over to page, on page 1014, table 48.6, is the interventions for seizures. There is a whole list there of seizure precautions. I've gone through all of those already. And then nursing care during a seizure. So make sure you know that little box as well. Traumatic brain injury, a TBI, is a major cause of death and disability in adults. Young men take up a larger proportion of brain injury victims, I think because men typically are a little bit more daredevils, maybe? I don't know. And so as far as the etiology of that, traumatic brain injury can basically happen from a lot of different things, but motor vehicle collisions count for the most traumatic brain injuries. Falls, sports-related injuries, and violence are also common causes of that as well. Your book here talks about closed head injuries, non-penetrating injuries, acute head injuries, penetrating injuries. So if it's a closed head injury, that means that there actually has not been, it's just called no actual open injury whatsoever. You've got bruising, maybe some tearing of brain tissue and vessels, but basically the skull is intact. If it's an open head injury or penetrating, that means that's a break in the skull. If it's an acceleration injury, that's a term we use to describe a moving object hitting a stationary head. The example your book talks about is when somebody's been hit in the head with a baseball bat. Or it could be they've been hit in the head with a baseball itself. So that can be something that, is something that could be a dangerous injury. Your book talks about the deceleration injury. Make sure you know what that is, the acceleration and deceleration injury, and then rotational injuries. Your book also talks about concussion under the traumatic brain injury. A concussion is considered a mild brain injury. There can be a loss of consciousness for about 5 minutes. Concussion is characterized by headache, dizziness, nausea, vomiting. They may have amnesia before the accident or immediately after. So when we do a CT on them or an MRI, there should be no skull or drum injury. We really won't find maybe a lot of abnormalities from a concussion. A contusion is characterized by bruising of the brain tissue. A lot of times it is accompanied by hemorrhage. With contusions, if you have a brainstem contusion, of course you're going to have level of consciousness that's going to be affected. That decreased level of consciousness can be something that is a permanent thing, or it may be something that you have temporarily and then it goes away. If the autonomic nervous system can be affected by edema or the hypothalamic injury, and if the autonomic nervous system is being affected, then you're going to have an increased rapid heart rate, and the respiratory rate's going to be rapid as well. You're going to have fever and diaphoresis, and this is something that must be reported immediately to the healthcare professional or the RN, because when we have that rapid heart rate, that rapid respiratory rate, fever, and diaphoresis, then obviously we have some major problems going on, and we need to have that seen about immediately. Your book talks about subdural hematomas. It talks about epidural hematomas. The thing that you need to know about those is just know the differences. Diagnostic tests are all the same tests we've already talked about, CT scans and MRIs. Those are pretty much the two major ones. The surgical management is going to be pretty much the same thing that we're going to be talking about later in the chapter about intracranial surgery. I'm not going to go into that right now at this particular moment. Medical management is really that we just want to control that intracranial pressure. We're going to do all the same things that we pretty much have done when we covered the intracranial pressure piece. So, we want to make sure that we're not doing anything to this patient that's going to increase that intracranial pressure. Complications of a traumatic brain injury can be a brain herniation. A brain herniation is a lot of times when that brain actually herniates, it's just displacement of brain tissue out of its normal location. And if that happens, usually it results in brain death. And at this point, it's really important that, the patients who experience brain death, their families know that this person would be suitable for organ donor candidates. And for some family members, the opportunity to donate their loved ones' organs provides some sense of purpose in that death. But those are some conversations that have to be made. And if you as the nurse doesn't feel comfortable with that, that's when you would want to contact the organ donation procurement folks, and then they will come in and actually have those conversations with those family members. Other complications, diabetes insipidus, you've studied that before in a previous lecture. Acute hydrocephalus is just nothing more than cerebral edema that can interfere with your cerebral spinal fluid. Vital signs is direct trauma to or pressure on the brainstem can cause fluctuations in blood pressure, cardiac rhythm, and respiratory pattern. Treatment, once again, is aimed to control that intracranial pressure. So we're going to do the same thing we would have done for increased intracranial pressure. Okay, as far as rehab goes, once this patient is stabilized, we're going to evaluate them to be discharged to a rehab facility. This patient may have to be taught to function independently again. In some cases, we realize that, especially if there's severe brain damage or this patient's still in that comatose state, that rehab is not an option. And so at that point, then we just might want to think about comfort care, palliative care, or as we call it, custodial care in a long-term care facility. So now we're moving on to brain tumors. Brain tumors can be malignant. They can also be benign. A lot of times brain tumors, they can have vague symptoms. We may sometimes want to think that the patient may have another disease going on, or another, they may have we may just think, well, they've got a severe sinus infection, or we may think that they are having migraine headaches. When in essence, when we start doing diagnostic tests is when we realize, no, this patient's got a brain tumor. The signs and symptoms are really going to be just wherever the location of the tumor is in the brain, and the rate of the growth. And so the most common symptom we see, the early symptom is fatigue. Other symptoms may be seizures, sensory motor deficits, nausea, vomiting, headaches, personality changes, confusion, speech, vision disturbances. Therapeutic measures, obviously if they think that the doctors can go in and remove part of the tumor as much as they can, they may decide to try to do the surgery. Medical treatment a lot of times is aimed at just controlling the actual symptoms, especially if that patient starts having seizures, and they wouldn't want to go on medications to kind of control that. And common medications that we do use is dexamethasone, which is Decadron, which is a steroid. A lot of times we give these patients this particular medication to lessen the edema and reduce their symptoms. And a lot of times that this medication is very helpful and useful in controlling their symptoms. Radiation therapy is something that sometimes we give. We may give it anywhere from 5 days to 6 weeks. Really depends on where the brain tumor is, how large it is. They may do the radiation therapy to try to shrink the tumor, to try to alleviate some of those symptoms. Chemotherapy is something else they may do. Really depends on, what the brain, if the tumor is related to cancer, then the chemotherapy sometimes will work. Other complementary alternative therapies, the rate of success is not as high, especially if it's benign. But, they're not to say non-traditional therapies have not worked. So you might want to encourage your patient to look at options in a rational manner. Acute and long-term complications, it's very difficult to decide what the long-term complications might be. It really depends on the tumor size, the growth of it, if the treatment is that we've tried, if it works or not works. Okay, intracranial surgery itself, the primary purpose of this is to remove the mass lesion. And so, we might go in and actually remove the lesion itself. There's some different kinds of surgeries they can do. The craniotomy is the surgical opening in the skull. And then a craniectomy is a term they use to describe removal or part of the cranial bone, and cranioplasty is the repair of the bone or use of prosthesis to replace the bone following the surgery. So what is the goal? The goal of intracranial tumor surgery is to try to completely remove that tumor. Sometimes if we can remove it all, we call that debulking. If we can't, we're going to try to remove as much as possible. Intracranial surgery does require the patient to be under general anesthesia. Very rarely do they do a procedure that requires the patient to be awake and cooperative. Preoperative care, as far as what we would do for a patient undergoing intracranial surgery, is the same as we would do for all other surgeries. Biggest thing is patient education is going to be important. We want to make sure that this patient is getting all this information, their education up front before they have the surgery, because they are going to be more receptive to learning about what's going to happen and that sort of thing. Family members, you want to get them involved as much as possible, because sometimes when you're trying to talk to this patient preoperatively, they're nervous, they're anxious, and so they may not retain as much information. And if you've got a family member there, that family member can help decipher some of the information, and maybe can remember some of the information and be able to pass that information on. A lot of times these patients are very anxious prior to the surgery because this is a serious surgery and it's a big surgery, and you start talking about cutting into somebody's brain, or skull, then they get very uptight. They're very fearful. They may ask, they may ask questions, they may not. Different people respond to fear and anxiety in different ways. And so, one thing that we can do is let those patients and family members go into the ICU, let them see, what it's going to be like in the ICU. You might show them, the different machines and all that they may be hooked up to. You might want to, show them, what the ventilator looks like. You might want to show them what the IV pumps look like. You might want to tell them, you might have 3 or 4 pumps with different lines going in. You might want to show them what an arterial line looks like. You also want to, a lot of times, make sure that this patient is aware that, if we're doing cranial surgery, obviously we're going to have some of their hair is going to be shaved off. And really, depending on where it's at, they may have quite a bit of their hair shaved off. I have a first cousin that actually has a benign brain tumor, and she has extremely long hair. Well, when they did surgery on her, they were able to shave up underneath her long hair, so when the top layers were completely laid down, you could not tell her hair had been shaved. So a lot of times they do try to, especially women, they're more have a lot more dignity about their hair, and so they will try to be able to, keep it to where maybe it can be hid if they can. You also want to let these patients know that, their face may be swollen after surgery, especially around the eyes. They may have some bruising. They may want, especially men, even women too, if they have had quite a bit of their head shaved, they might want to wear a scarf or a hat, even after those dressings are removed, just to cover up the scars. Alright, spinal disorders. Herniated disc are a very common health problem. These patients typically have a lot of pain. They may have some paresthesis or paralysis along that nerve path. And it's not uncommon for somebody to have more than one herniated disc or have different herniated discs in different areas of the spine. Basically, what a herniated disc is, it's when the actual vertebrae herniates and that disc inside moves to an out of its normal anatomical position. And a herniated disc can be related to a fall. It could be because you've lifted too much a heavy object. It can be related to motor vehicle accidents. And sometimes there's just not a cause. We can't come up with why this patient has one. Some people's body just herniates disc, and we don't really have any real reason. Signs and symptoms is that a cervical disc herniation causes pain, muscle spasms in the neck. It can cause them to have decreased range of motion because they have the pain from that. And really it depends on exactly where the herniated disc has occurred as to really what symptoms they may have. It's very uncommon for thoracic, the disc in the thoracic area to become herniated. We typically see it in the lumbar area and the lower part of the back. And so like L5 to S1 can affect bowel and bladder incontinence as well. If you'll see, again, it talks about the what's up mnemonic. That's a very common way. If you can remember that, that's a great way to assess symptoms of a herniated disc. Medical treatment or diagnostic test, of course, an MRI is the best way to be able to look at these, see if it's a herniated disc. And it's probably one of the safer ways as well. As far as therapeutic measures, healthcare providers are going to try to go with more conservative treatment instead of just jumping straight to surgery. Surgery a lot of times is what it requires, but we don't want to just jump to that. We're going to try other measures first. Medical treatment that we may try is obviously rest, have 1 or 2 days of bed rest, and then gradually increase back into the activity. Physical therapy, it can be very useful, so a lot of times they will recommend physical therapy, ultrasound, the use of ultrasound, electrical stimulation, heat, ice, deep massage, all those can really help too. Traction, if it's in the cervical area, sometimes physical therapists will apply the cervical traction. and see how that helps. Medications, a lot of times they give muscle relaxers, and that's just short term. That's try to help with the muscle spasms. There is anti-inflammatory medications. NSAIDs are very commonly used. Epidural injections is something else they may use. We try to avoid opioid pain medications, because, and if we have to use them, that they're only short term because, it's hard. A lot of patients can get very dependent on these medications. Other alternatives they may use is topical lidocaine patches, NSAID patches. They may use even some medications for neuropathic pain like Neurontin or Lyrica. Other complementary alternative therapies is using a TENS unit, which is a transcutaneous electrical nerve stimulator, which is, they put the small electrodes on the skin. They do low voltage electrical current, and that sometimes works and helps with those, especially those muscle spasms. Surgical management, like I said today, we're trying to stay away from surgery. We try to use a lot of the other conservative measures. A laminectomy is probably one of the more common options for surgery, and they just basically go in and remove one of the lamina and flat pieces of bone, put bone on each side of the vertebrae, and they just do that to relieve the pressure. A discectomy is where they actually go in and remove the entire disc. A spinal fusion is sometimes done, and like with all of these surgeries, usually they're discharged within about 24 hours of surgery. Complications after surgery are just like that of pretty much anything. Hemorrhage can be a definitely a complication. Nerve root damage, where they've actually damaged part of the root, and then reherniation. That's a common thing. It can reherniate. I actually took care of a guy one time that we did surgery on, and he went home, and he had been home about 3 or 4 days and went to extreme pain again and came back into the hospital and had a reherniated disc. And so we actually had to redo his surgery. That's not something we typically want to do, but sometimes that's what happens. And you can herniate or herniate an adjacent disc as well. Spinal stenosis is a condition in which the spinal cord compresses the spinal cord. Arthritis is the common cause of this. Patients can have surgery sometimes for spinal stenosis, because we've got to be able to relieve that spinal cord. All right, on page 1026, spinal cord injuries. Injuries of the spinal cord can affect anyone. It takes the greatest probably toll on young people, and spinal cord injuries can happen really pretty much any cause. Motor vehicle collisions are still the most common cause in the United States. Females are more often injured by falls. Males are more injured by acts of violence or contact sports. Your book talks about different signs and symptoms, and really your sign and symptoms going to depend on the level of the cord that's damaged. If you look on page 1027, figure 48.1, make sure that you know if it's a C1 to C3, that's usually a fatal injury, and then C4 is quadriplegic, paralyzed from the neck down. C5, 6 is quadriplegic with some arm and shoulder movement. C7 and 8 is quadriplegic with some arm and hand movement. If it's a T1 through T6, it's a paraplegic, some trunk involvement, legs are paralyzed. T7 through 11 or 12 is paraplegic. Good upper body abdominal strength, may function well in a wheelchair. And then an L1 to an L4 is paraplegic, may learn to walk with crutches or braces. So it just kind of tells you there that depending on the level of the injury as to what the patient may actually have as far as function goes. Then we're going to look at spinal shock. Spinal shock it's basically is immediately after a spinal cord injury. The cord below the injury stops functioning completely, and then that's when a patient can go into spinal shock. There is a lot of complications that can go along with spinal shock, or really with spinal cord injuries in general, and that's infection, deep vein thrombosis, orthostatic hypotension, skin breakdown, renal complications, depression, and substance abuse, and autonomic dysreflexia. And we're going to talk a lot more about autonomic dysreflexia. Autonomic dysreflexia is a life-threatening complication. It occurs in patients with injuries above the T6 level. Okay, so it's an injury above the T6 level. And basically what happens is, when we say it's an autonomic dysreflexia, so the spinal cord is being impaired, and then you have problems with the sympathetic, parasympathetic divisions of the autonomic nervous system. The most common cause of autonomic dysreflexia is a bladder distension. So what happens with this autonomic dysreflexia, that spinal cord injury causes your body to activate the sympathetic system. What happens with the sympathetic system? The fight and flight response kicks in. And when a patient has the autonomic dysreflexia, and the cause of it would be that bladder distension. That bladder fills up, it starts pressing on, getting full, and then starts that reaction, okay, of the sympathetic system. Stimulation of the sympathetic nervous system results in cool, pale skin, goose flesh, and vasoconstriction below the level of the injury. So if you start seeing those signs, or you see a blood pressure can rise as high as 300 millimeters per mercury systolically. And the parasympathetic response results in vasodilation. The patient may have a pounding headache as well. So we want to make sure that if we see that, it's life-threatening, it has to be reported immediately. With it saying the bladder distension, of course we would want to try to get that bladder decompressed as soon as possible. Emergency management, obviously, is respiratory management, GI management. So if they hadn't had a bowel movement, we want to make sure that they have a bowel movement. As far as the GI goes, to prevent that bladder distension, we're going to put an indwelling urinary catheter in, and then also protect skin integrity while spinal shock resolves. Surgical management, the goal is to stabilize the bony elements of the spine, relieve the pressure of the spinal cord. Okay, we're actually going to stop there, and then I'll continue on the part 3 of this, and we'll talk about spinal cord injury.